5, 4, 3, 2, 1. Let's go. Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi, and welcome to Diary of a Kidney Warrior podcast. My name is Dee Moore, and I am a kidney warrior. This podcast is dedicated to encourage, educate, and inspire as we explore all aspects of kidney disease, related chronic illnesses, and health. In today's episode, we continue our two-part series, Beyond the GP, Making Primary Care Work for Kidney Health. Today in part 2, we'll be talking about knowing your risk factors, why urine tests are so critical, what to expect if you're living with diabetes and CKD, when to ask for a referral to secondary care, and the tighter targets that can help protect your kidney health. This conversation is all about empowerment, prevention, and practical steps you can take to make sure your care is timely, personalised, and effective. And just a quick note before we begin, as with all interviews here on Diary of a Kidney Warrior podcast, the information shared is for educational purposes only and should not be taken as medical advice. Please always consult your healthcare team for guidance about your individual care. Hi, and welcome to Diary of a Kidney Warrior podcast. How are you doing today, Dr. Kristin?
Yeah, really good, thank you.
It's really good to have you back on the podcast. Listeners, if you don't already know, my first interview with Dr. Kristin was episode 139, and this was part 1 of the Beyond the GP, Making Primary Care Work for Kidney Health. And so today we're recording part 2, following on from the various topics that we discussed in part 1. We looked at knowing your numbers, something I feel really, really passionate about when it comes to knowing exactly where you are with CKD. As I've said so many times, never accept it's fine when you're told what your kidney function is. No, know exactly what the number is. If you don't know the number, you don't know where you stand, because you won't know if you're in decline. You won't know what is going on. So yeah, please do check out that episode. We talk about, misconceptions. We're talking about self-advocacy. There's loads of information in there that you will find helpful. And today we're in the same vein of giving people information that's going to empower them for their kidney health. So please do check out part 1. So today in part 2, we're going to be following on from those topics. And so we're going to start with knowing your risk factor, because it's so important to know, because again, a lot of people will say to me, I'm fine, I've got nothing to worry about when it comes to kidney disease. I don't know why you keep going on about it. But there might be other factors that mean you're at risk of developing CKD. So we really want to highlight this information so that people know. Dr. Kristin, my first question is, what are risk factors that people need to be aware of?
So it always surprises me that we know that diabetes is a big cause or a big potential cause of kidney disease, but yet patients repeatedly tell us that they weren't aware that diabetes could impact on their kidneys. Diabetes can impact on kidneys in 2 ways. It can either cause direct damage to the kidneys, and that typically leads to protein in the urine, or a type of protein called albumin. And that's why it's really, really key that you have your albumin-creatinine ratio, the urine test for kidney function, done every year. We know that in people with diabetes in particular, the urine test can become abnormal 2 or 3 years before the blood test starts to drop into that CKD stage 3 range that we talked last time, is a bit of an artificial line that's drawn at the eGFR dropping below 60. So it's really, really important that, if you've got diabetes, that you're aware that those regular checks need to be done. I think people with diabetes are offered regular checks for their diabetes, so they are coming into the surgery. But there are lots of other people that are at risk. So people who've got high blood pressure, people who've had heart problems, in particular heart attacks, or people who've had angina, or they've had stents put in their heart. people with high cholesterol. So anybody at risk of heart attacks or even strokes, those sorts of people should be also having their kidney function checked regularly. So at least once a year, but it depends a little bit on what your kidney numbers are. Again, back to knowing exactly what those numbers are, so you know how regularly that should be done, but at least once a year. And then there's some of the things that are a little bit more tricky sometimes to find. So when we search in GP records, we can search for people who have diabetes, or if they've got blood pressure, or they may be on a medicine for their blood pressure. But if you've got a family history of kidney problems, it's really important to have your kidney function checked. And that's checked with the blood test and the urine test, as we discussed last time, because some things do run in families. And so it's really important that, you get that checked. And you can go to your GP. There is, as part of Kidney Care UK's Bloody Amazing Kidney campaign, there's a kidney risk checking tool and a letter you can print and take to your GP that says, I'm at increased risk and I'd like to be sort of screened, if you like, for kidney disease because I've got some risk factors. People on certain medications should be followed up regularly and have their kidneys tested. That often happens in specialist clinics. So thinking of people with arthritis who take drugs to modify their arthritis disease. So rheumatoid arthritis would be one example, but it's not the only one. And those people are looked after often by rheumatologists. And so they have their kidney function done regularly because of the medicines they might be taking, but they also don't always have the urine protein test done. So it's really important to be having both of those. And otherwise, I suppose if you've got chronic conditions like gout, that's on the list of things that should be kidney checked every year. There's a list in the national guidelines for kidney disease of people at risk, and it spells out the people who are most at risk. But I think for me, the key people that need to be having that every single year are those people who, even if they have it checked and it's normal, if you're diabetic, it should be checked again next year. It should be checked again the next year. It should be checked again the next year. Whereas I guess if you had a family history of kidney disease, you might have it checked. And then if everything's fine, that may not need the same kind of degree of future monitoring. So it's really important to know your risk and talk to your GP about that.
Do you know, I wasn't aware that the signs of CKD appear in your urine before they do in your blood. And to know that 2 to 3 years before, that is a massive difference. There's so much damage or decrease that can occur in a 2 to 3 year period. So getting that information 2 to 3 years earlier could be the difference between being on dialysis and not being on dialysis. It is so important that you get your urine checked then. So please, listeners, if you are diabetic, please make sure that you get your urine tested.
Absolutely. And I think one of the things that comes up a lot is it having to be the first sample of urine in the morning. But the guidelines were changed a few years ago to make it easier for both GPs, but also for patients. Any sample will do to start with. And then sometimes if it's abnormal, we might say, let's repeat it first thing in the morning. But don't let that put you off. Any sample at any point in the day is good for that screening test. And as you say, for people with diseases that are known to cause protein in the urine, it can pick it up a bit earlier. Also, we've got new medicines appearing all the time at the moment for kidney disease. It's quite an exciting time. And some of those you can only have if we know how much protein you've got in your urine, because it has to be over a certain level. So it's super important that you get the most opportunity to have access to any of the treatments, because we know they're so good at keeping people off dialysis. So yeah, and I guess other risk factors would be things like certain medications. So non-steroidal anti-inflammatory drugs are one of the ones that comes up a lot. So those are things like ibuprofen and naproxen and diclofenac. And remembering that even the gels, even though they're less risky, they're still a risk. So for people with chronic kidney disease, we tend to say those should be avoided as much as pragmatically possible, really. So those, if you're on those medications, you shouldn't be on them long term. And if you are on them longer term, because I guess there are sometimes exceptions, your kidney function should be monitored. People will know that drugs like ramipril, so the ACE inhibitor drugs, these are blood pressure drugs, or candesartan, losartan, a whole list of them. Water tablets, furosemide is one of them. Indapamide is often used by GPs for blood pressure. You need kidney checks every year for those drugs. Some drugs like lithium would be other ones that we'd monitor quite closely. So that's used for people with things like bipolar affective disorder, because they can sort of damage the kidneys. So it's not for anybody to be alarmed and that they're on those medications if they need them for their health, but just being aware that they should have their kidney function checked regularly just to make sure that it's nice and stable and it's not dipping in any way. And the other one of my GP colleagues actually mentioned to me recently is that if you've had a dip in your kidney function, so what we call an acute kidney injury or AKI, that should be followed up both, in the acute sense to make sure it's settled, but also a year later you should be having another kidney function check just to make sure that that dip hasn't turned into anything more long term. So there's quite a long list of things really that put people at risk. So if you're not sure, it's worth just chatting to your GP and using the Kidney Care UK checking tool, because that's a good starting point. It flags some of these risk factors and helps just direct you towards a GP if that's what's needed.
And just to add that I will put the link for the Bloody Amazing Kidneys and the risk factor checker in the description box. So following on from our discussion about risk factors, and we've discussed quite a few, and so I know that it's not possible for us to go in depth about each one, but I wanted to focus particularly on diabetes as it's the number one cause of CKD in the UK. So in terms of focusing a bit more about diabetes, what other things do people need to be aware of in terms of monitoring and their care as a patient with diabetes?
Yeah, so I think the approach to diabetes needs to be holistic as well. So it's sugar control and blood pressure control and cholesterol control. And as we said last time, it's making sure that if you've got kidney disease, that those things are done to quite tight targets. So I think it's not often realised that the standard targets for things like blood pressure don't apply. There's tighter targets for people with diabetes, and especially diabetes and kidney disease. And when diabetes affects the kidneys, as we've said, you get protein in your urine, which means that you want the blood pressure to be better than normal. So I'm always aiming for that blood pressure to be less than 135, lower if I think the patient will tolerate it, because that takes pressure off the kidneys and stops them pushing protein into the urine. HbA1c, which is obviously the monitoring test for diabetes, is less reliable when you get towards the dialysis end of the spectrum. So often those patients are being monitored with either blood fingertip prick testing. Often dialysis patients now will have the Libra, the types of devices. There's a few of them on the market now that monitor their sugars on dialysis. But I think in terms of like how in primary care, how frequently things should be monitored. So if you're on an annual diabetes review check, then your kidney function will be done at that check. The urine test should be done at that check. So it should be done at least once a year. What I would say is that if you're developing chronic kidney disease, then that monitoring will need to be tailored to what's happening with you. So if you've got chronic kidney disease and the kidney function eGFR test is getting worse or the protein test is getting worse, I'd expect you to be seen more frequently for monitoring. And again, in the past, we used to have these sort of guides that were everybody with CKD stage 3 gets seen every 3 months and everybody with CKD stage 4 gets seen every 2 months. And it's again sort of less helpful because it depends on how stable things are and what you're changing. Because obviously if you're changing medications, you might want to again monitor kidney response to the medication, monitor what's happening with the diabetes testing and the HbA1c and just make sure it's responding nicely to that. And that's, I guess, where the people we talked about in the primary care team really come in, because we know, and I'm sure you've experienced it as a patient, sometimes you start these medicines and it's, let's start at this dose, let's keep pushing it up until we get to whatever target. And actually getting that done can take quite a long time because you have one appointment and then medicine's started, it's prescribed, you pick it up, you start it, there's a blood test, that has to be looked at, the prescription has to be done again. It takes quite a long time. So people like the pharmacists in the primary care teams can really help getting on top of things when they're not as under control as we might like, to try and just get everything optimized together. And I think the thing that myself and primary care colleagues are very mindful of is that if you've got diabetes and you've got kidney disease, you're likely to have blood pressure. You can suddenly rack up a huge amount of appointments between primary care and secondary care, seeing different people in different places at different times. And it often can become sort of a full-time job managing where you need to be on a particular day and who you're going to see. So using people like the pharmacists can sometimes be helpful for that, because the pharmacist can deal with all those things. They can help with your blood pressure, they can help with your cholesterol, they can help with the diabetes medicines, they can check that the medicines aren't interacting in a way that could cause side effects, they can review the side effects, they get longer appointments often than the GP might have, and they're able to just take a step back and a much more holistic look at all your medicines to make sure that things are as good as they possibly can be in a shorter time frame. So I think that's really important, especially for diabetes. But I think the key take home for me, it has really shocked me, kidney carers, surveys, when patients saying that they haven't heard that diabetes affects your kidneys. I think that's a message that's somehow getting lost in the system, and it's really important that people know that it's not just your eyes and your feet, that in your heart and those things. Actually, it's really important that your kidneys are checked and monitored as well.
So really, there's no hard, fast rule in terms of frequency, but it should definitely be more frequent than yearly.
Yeah, so if you have very stable diabetes, diet-controlled diabetes, you've had your annual check, your blood pressure's normal, there's no protein in your urine, your kidney function's normal, and I mean, by that, I mean ACR is normal, eGFR is normal. An annual review for someone like that is perfectly appropriate. So you would just have your kidney function checked. In reality, you probably end up having it in the middle because you'll be on a medicine that needs monitoring, but a year would be fine. But most people with diabetes, you're changing tablets, you're optimizing diabetes medication. There's things that are changing that you'd want to be checking, and the kidneys fall in as part of that. I have to say, if someone has diabetes and I did a urine protein test and it was negative, we'd probably just do that next year. The blood tests often get done more frequently depending on what's happening with that particular individual or patient. I think primary care have a very low threshold for checking people's kidney function because kidneys affect so much. So again, in some of the research work we've done, I think someone said, I always tick the box for kidney function. Every time I do a blood test, I always tick that box. So we're doing it all the time. But I'm not sure how visible that always is to people that are living with those conditions. So just keeping an eye on that. And as we discussed last time as well, the blood results frustratingly don't always end up in the same place and visible in the same place to the GP or whoever's looking at them in primary care. The hospital bloods might not necessarily be on that system. So if you're noticing, hold on a minute, there's a bit of a creep there, I had that blood done in the hospital for some reason and there's a bit of an abnormality, it's useful just flagging that as well, because it might need to be monitored a bit more frequently than that is being picked up just by the searches and things that we do in primary care. I guess the other thing to mention is that I think we're not perfect, but we're better at asking people with diabetes to bring the urines in. But what often doesn't get picked up is people with high blood pressure, and making sure that they also have that urine protein test done at least once a year. And as we talked last time, blood pressure can often be one of the early signs of kidney problems, but it doesn't cause symptoms in the same way kidney disease doesn't cause symptoms specifically in the early stages. So really, really important just to make sure that if you've got blood pressure problems that you're bringing in that urine albumin-creatinine ratio and asking your primary care team to send that away and test that for you. And if you don't see a result from that, I would say just ask back to knowing your numbers. I know we had a problem with our system locally where if it returned as 0, so there wasn't any protein in the urine, that wasn't appearing on the systems. So always ask if you're thinking, hold on a minute, I never got the result of that. I need to know what the number was. Just ask. And anything above 3, isn't a cause for alarm necessarily, but it just should prompt primary care teams to think, could their blood pressure be better? Do we need to change the medicines they're on to be more protective of their kidneys? It just should flag as a way of just identifying where we can make the care a bit better for that particular individual.
So we've discussed a lot of different risk factors there. So if you fall into any one of these categories, please do discuss it with your primary healthcare team to make sure that your kidney health is being monitored. So are you automatically referred to secondary care, or do you need to ask for that referral?
So sort of feeds nicely on from what we've talked about risk. So one of the main criteria that should prompt primary care teams to refer people to secondary care is using something called the kidney failure risk equation, sometimes called KFRE. And it's like a risk score. So people will possibly be familiar with Q risk, which is a score that predicts how likely you are to have a heart attack or a stroke in the next 10 years. Sometimes we don't call it Q risk, but we often talk about that score with people in primary care. And this is like sort of a similar thing for the kidneys, and it predicts your 2 and 5 year risk of needing dialysis. So sort of 2 and 5 year risk of worst case scenario, CKD stage 5. It only works if you've got a GFR below 60. So it's those people from stage 3, and you have to have had your urine protein test to calculate the risk. So again, going back to the importance of having the urine test, your GP can't calculate that score if you don't have both those bits of information. And there's a really useful website, kidneyfailurerisk.co.uk, where those numbers you put them in, you can put in it's your age, your sex, your eGFR, and your urine ACR, and then it will give you a risk. And as a patient, if you do that or get your doctor to do it with you, or pharmacist or whoever's doing that consultation, it then pops up with loads of really useful bits of information, both about what you could do together to improve your risk, but also information for patients about, what does that actually mean for me and what might happen next. So it's quite a useful tool. So I think that's one thing. And any risk, 5-year risk above 5%, that should be considering a referral. And the reason it's not automatic is because obviously we might see that in a patient for whom it's not appropriate for them to be referred, or they don't want to be referred. So not appropriate should still be discussed with them and their family, but that might be someone who's resident in a nursing home for whom, traveling to an appointment in a different hospital might not be the right thing. And sometimes in that situation, the GP will still get advice from secondary care. They'll say, I've got this patient, their kidney failure risk score is higher than 5%. I don't think they should come all the way to you, but have you got any advice about things that we could do or medicines we could change to keep them as well as possible and keep them feeling as well as possible? Because even if you're in a group where you decide dialysis isn't for you or transplant that isn't for you, you should still be able to have treatment to make you feel as good as possible and manage some of the symptoms associated with kidney disease. So I think that's one bit. Other things that should be referred on to secondary care. So the KFRE is a great tool, but it's a 1-point snapshot. So it's your kidney function, blood and urine on a day or within a few days put together into a score. But it obviously doesn't necessarily bring in what you described before, where your kidney function is deteriorating. It doesn't pick that up. So we have a caveat to that if the kidney function is deteriorating across the year and your GP notices that it's reducing, so it's changing stage or it's deteriorating by more than 15%, that should be a flag. And in our systems now, you used to sort of have this kind of refer, not refer, whereas now a lot of kidney units have something called advice and guidance, where your GP can write, or anybody in the primary care team can write and say, I've got this patient, I'm worried about them, their kidney function's getting a bit worse, they have these risk factors, these are the medicines, what would you think we should do? Do you think you need to see them, or do you think there's things we can do in primary care first? Because the newer medicines, most of those can be started in primary care. Not all of them, but a lot of them. So sometimes the advice from secondary care might be start some medicines, get the blood pressure a bit better, work a bit harder on controlling the diabetes, add in some of the newer medicines, and monitor and see whether or not we can sort of improve things at that point. Now, clearly, if people are getting towards stage 4, stage 5, you're expecting that a nephrologist is likely to want to see that patient. I guess, again, with the caveats of, perhaps someone who is a bit older, kidney disease may be really stable, and they might not actually wish to see the specialist, because at the end of the day, it's a patient's decision what level of care they want to have for themselves and what sort of things they would feel are acceptable with the rest of their life and health. It should never happen automatically. So if you're seeing someone in primary care and they're worried, they should be saying to you, I'm going to reach for some help. And that should appear in your GP record now, the advice and guidance results when they come back. So again, if you're in that boat where there's a bit uncertainty or someone's not sure, there's always that opportunity to reach out to secondary care and ask the question. And in my other life, I do some research and we've done some interviews, and all the GPs we spoke to across England certainly said that they thought that process worked really well, and that nephrologists are generally helpful people who respond promptly and give good advice. So there shouldn't be any reason not to reach for that advice where you feel it's needed.
It's unfortunate that I do have to make this statement, but in my experience, and obviously we're talking about my experience, so this isn't a study and this isn't scientific fact, but I know of so many times when somebody's kidney function is in decline and nothing is actually being done. They don't even know that they have kidney disease, moreover being referred to secondary care. But say if somebody is aware that they've had a diagnosis of kidney disease and that their kidney function is in decline, just to make things a bit more easier, because not everyone's good at maths, let's face it. Not everyone understands how to crunch the numbers. But at what percentage then of kidney function should you be saying, I should be under the care of secondary care, if that is not being done by your GP or your primary care team?
So it's a really good question. And the last version of the GP guidelines about kidney disease had this GFR 30 sort of absolute hardline cutoff. And that is probably a useful rule of thumb, but I think it's not an absolute. So it makes me a little bit anxious when that comes back as a, let's wait and let's refer the patient at that point, because that's absolutely not what we would be advocating. So if you're, like we said last time, if you're young and otherwise fit and healthy and your kidney function is going 70, 60, 50, 40, I'm not going to wait till it gets to 30 to start speaking to somebody in secondary care. That's a problem. And that's why those sort of absolute cutoffs are less helpful. And it's more about how rapidly things are changing and what other things are going on around it. But I would say, as a rule of thumb for your listeners who, all these scores and things are useful and they're useful to know about, but they can be quite complicated, is, CKD stage 4, stage 5, you'd want to have at least some discussion with at secondary care. So for some people, that will be full referral, straight in, being seen by a nephrologist. For other people, it might be, well, actually, let's see, are things stable? Have we got you on the best available treatments for your kidneys and to keep you feeling as well as possible? And actually, I would always want to have discussions at that point of what does the patient want? So often when you have conversations with particularly older people, and obviously I'm probably able to do that in a more informed way, but talking about things like dialysis, some people will say, actually, that's not something that I would ever want to consider, and that's fine. But actually, we need to just make sure that we join the dots with the other bits and pieces around that. So making sure that, they're feeling as well as possible, and any symptoms that they're experiencing are being monitored and treated either by secondary care, by primary care, or together, which is the ideal situation, really.
Again, it's a statement that is not pleasant to make, but unfortunately, again, because of situations that I've been made aware of, I have to ask this question. With what you've said in mind, obviously, we're not waiting to get to 30% and then taking action, or everything has to be in its right context. Like you said just now, if your kidney function, especially as a young person, is declining very quickly, then you're not waiting for that long. But for somebody who is in the position of being at that 30% or even less, and their GP or whichever health professional from the primary care team is saying to them, well, you're okay, you've got nothing to worry about, you're not anywhere near dialysis. What would you say to them in terms of really getting through to them that no, this is the point where they should be referred to secondary care?
So I think for me, if anyone's worried, a discussion is often helpful, just to sense check and make sure. As a GP registrar, there's so much I don't know. And so it's often helpful to reach out to secondary care and say, this is my thinking. Are you on the same page? Do you think I need to do something else? Because that's what we have specialists for. So I think it's encouraging them to do that. Where I work, the renal unit only has advice and guidance as a single point of access. So any question that GPs have, they put in that form, and then a secondary care, they will review and they will decide, actually, we probably need to see that. So it takes that sort of pressure for the GP to decide, is it a referral, is it not a referral, away a little bit, because they just are asking a question and they're getting advice that's, bespoke to the question they've asked. I think that is quite helpful in a way. GPs, as part of the contracts this year, are encouraged to seek specialist advice in that way, with the hope of avoiding people deteriorating to the point where they need specialist input. So that's one of the government's new incentives, if you like, to try and bring care earlier along the pathway into more preventative care. So I think if you're struggling, I would just be saying to whoever you're seeing in primary care, would you mind just running that past someone in nephrology via this? It's called advice and guidance, and it is what it says on the tin. It's to try and get a specialist to say, they may say, yeah, you're doing everything you can, that sounds fine. But often what's useful is they will say, let us know if this happens, if it gets to this point, if they develop protein in the urine, if that's not successful, if you're not winning, let us know when those things happen. Then the GP's thinking, and the patient can be thinking, okay, this is where the wriggle room is. That's where the red flags are. That's where I should be getting concerned. So I think it's generally quite a helpful process, just to, allay all those fears that you mentioned, and just means when it's a specialty I don't know about, I feel I can go back to the patient and say, look, I've had a quick chat via this service, or however it happens in your locality, because other places have different ways of doing the same thing. But, I've had a chat and the specialist doesn't think there's anything else we should be doing, or they've said, this is what we should do next. I think that's quite helpful. I guess one thing that comes up quite a lot as well that's worth noting is that chronic kidney disease is quite common as you get older. So, depending on what numbers, we talked a lot about numbers, haven't we? But what numbers you read, maybe as many as half of people who are in their sort of 70s and 80s are going to have CKD, most likely stage 3. And different people develop kidney disease because of their background risks. And as your kidneys get a bit older, their sort of ability to tolerate the risk factors that they've had. So things like blood pressure and cholesterol and so on that we've talked about before. Some people just are born with slightly lower kidney function in relation to others. And so what we see a lot is older people with chronic kidney disease stage 3 that is very, very stable. They've not got protein in the urine. It's maybe sat there for 10 or 20 years, bumbling in and around the same ballpark. And whilst it needs this sort of holistic overview of, are we missing anything? Is there protein in the urine? Back to remembering about urine tests. Are they on the right medicines and not the wrong medicines? Because as you get older, medicines can cause a lot of mischief for a lot of things, kidneys included. Then, actually it might be a case of there isn't really anything to be too worried about here. And whilst the kidney function will need checking on that annual basis, as we said, it might not in itself be a cause for alarm. And I think it's causing a lot of alarm to people who are older, because the advice they get sometimes is, oh, don't worry about that. It's just because you're a bit older. And that's not quite it. Not everybody who's older has CKD, but it is very common. So it's looking at that person as an individual. What's the CKD doing? Is there protein in the urine? Is it getting worse over time, or is it just sort of gradually bumbling along? I always say to people, you'll lose about a percentage point in GFR a year just through the natural process of things. So if it's gradually dipping down over the years, that's all right. If we're seeing, again, things getting worse or protein appearing in the urine, that's when we start to get a bit more worried and it might be more of a concern.
At what age then do kidneys naturally tend to decrease then? I mean, you said as you get older, but from what age is kind of like, for want of a better word, the normal age that things tend to decrease naturally?
So it's a really, really good question, and one that I've been bouncing off some clever nephrology colleagues recently, that we don't have, a bit like blood pressure, we don't have age brackets for when to worry about kidney function in older people. And so there tends to be this, either it's nothing, don't worry about it, or this, it's really serious, but you don't need dialysis. And there doesn't seem to be any sort of sensible sort of guide to what the numbers actually mean. I did read something that suggested you lose 1 percentage point every year from over the age of 45, which makes me slightly worried because that means that starts pretty early for all of us. But I think, the take-home message really is, I guess for me, I'm conscious that no two 80-year-olds are the same. And I live in Hampshire and Isle of Wight. We have 80 and 90-year-olds who sail yachts in the Solent. So it isn't just about age as a number. And so people should still have the opportunity to discuss and access those treatments. But I guess what I would say is, in terms of dialysis, which is often people's biggest concern, there are a lot of people who sit nice and stably in CKD stage 3 in their 70s and 80s in particular, and older than that. And that's not going to meaningfully cause them any concern. I guess the caveat is that those people are higher risk of things like heart attacks and strokes. And that's why it's really important that the care is holistic. So whoever's seeing you in primary care is seeing which medicines are you on, not just for your kidneys, but for your heart and your blood pressure and just keeping you well, and that those medications are appropriate for you. So it's no good making your blood pressure 120/80 if you fall over and break your hip because you're dizzy. So we've got to be sensible, and we've got to take people, I think in particular older people, with a bit more care and a bit more sort of holisticness and a bit more individualization. We need to really be careful about what we're doing and work together to do that. So I appreciate that's like a lot of things we've discussed today. I've not been able to give you a straight, hard and fast answer because people are people and it would be wrong to do that. But I think what I'm trying to say is, if you're older and you see that CKD pop up on your NHS app, don't automatically panic and think that that means dialysis, because for older people, it's a very common thing that we see that can be well managed in primary care.
So for our final topic for discussion for this interview, I wanted to look at the targets for people with CKD in terms of their care, because I'm aware that because you have CKD, these targets are much tighter. What are these targets and what are the conditions that would change the targets for people with CKD?
So I think I always sort of joked, if that's the right term, with other colleagues, that nephrologists are always renowned for being a bit picky. And the reason that we're picky is that these things actually do really make a difference, just being really tight on control of things like blood pressure. So we talked last time about how, national targets for blood pressure set the target blood pressure to 140/90, 150/90 if you're over 80. But actually for patients with kidney disease and patients with diabetes, we're aiming a bit tighter than that. So we're aiming for 135 as the top number at the worst, if you like. So that should be the target. Now, obviously, if someone's a bit younger or a bit older, we might decide on some flex around that depending on how they get on with medicines. But we're just trying to be a little bit more proactive in making sure things are not just slightly inside, but they're actually well inside the targets and they're well controlled for that person. Same with things like cholesterol. So everybody with chronic kidney disease stage 3 to 5 should be offered a statin. And it's an offer because obviously statins are one of those quite contentious things that are covered in the media quite a lot. we know people with kidney disease more likely to get side effects. However, we also know there are other treatments that can be used for cholesterol. So it's an offer of a statin, but if the statin doesn't suit, there should be consideration. There's more than one statin. There's some that are better tolerated in people who have side effects. So that's one thing that can be considered. There's other medications. Some of them, in honesty, are maybe less good than statins, but they're better than nothing. So they should definitely be offered to people. And some people meet the criteria for specialist medicines for the cholesterol that require referral into clinics. And again, we know people with kidney disease are really high risk of getting heart disease and strokes. So it's being more on top of those targets and guidelines and not just sort of saying, oh, well, I've done that and the patient didn't want that or it didn't suit and moving on. It's actually just thinking, what else could we do that might help optimize that? Could we try a different type of tablet? Could we explore what the side effects were like and what we can do that's different? Everybody with chronic kidney disease, so even if you say a statin's not for me or I've tried one and it doesn't work, your GP is obligated to offer you that every year in case you've changed your mind. So that's not them trying to be annoying. I know it seems to frustrate quite a lot of people, but it's a sort of a natural thing. Just they're asked to check with you every year if you're eligible for a statin, if that's something that you still don't want to take for whatever reason. And that's your choice. You just let them know that's the case. And then diabetes control. So obviously, whilst there's nothing specific about kidney disease and diabetes in terms of adjusted targets in the guidelines, we know that people with diabetes are a higher risk. So, we would naturally be trying to make sure that their diabetes is controlled as much as is possible, rather than it just being sort of just within targets. And certainly we wouldn't want to see it drifting off in different directions without that being flagged, because that could be a risk. So I think those are the main things that I'm sort of notoriously a little bit picky about, is making sure, what is your blood pressure? You want to know the numbers. You want to know what the target is for you. It needs to be better if you've got chronic kidney disease than the sort of national target that's screened in the databases. Your cholesterol should be controlled by one way or t'other. And there are different ways of doing that. And those can be discussed. Again, pharmacists are your friends with knowing where the specialist drugs indications come in. And then diabetes, just making sure you're on optimal medicines. As people will be familiar with listening to the podcast, I'm sure injectable medicines for weight loss are soon going to become a bit more available in primary care. They're going to be quite ring-fenced to start with the idea they get to the people at highest risk first. So to start with, you'll have to have a collection of comorbidities as well as weight. But that's going to change then as we get more people offered medication. So definitely worth watching the space. I know our GP practice has messaged everybody to let them know that, we're on it and we're reviewing constantly what those eligibility criteria look like. We think those medicines protect kidneys as well. So obviously from a kidney point of view, it's really important that, people are offered everything that they could be eligible for at the right time. I guess the other thing to mention in terms of other targets is that as kidney disease advances through the stages, obviously the kidneys regulate lots of things. They regulate your blood count and whether you become anemic, and they regulate your calcium and your vitamin D and your bones and how strong they are. Those are tests that aren't always done by GPs because they tend to be a bit more specialist. So it's just sort of thinking, if your calcium is drifting down a bit, could you be vitamin D deficient? GPs are often quite good at checking vitamin D and replacing it, but not always. So that's one thing. I think if you're becoming more anemic, one thing I get asked quite a lot by patients is that the normal range for ferritin, which is the iron measure, goes up to 28, I think, locally. Whereas for kidney patients, we've got much higher targets for that, depending on how sort of severe kidney function is. Dialysis patients, we want it much, much higher than that. And so I think it's just questioning those things, and back to what we said before, if your primary care physician or pharmacist or nurse is not happy, they can always ask for that specialist advice and just sort of run it past someone who can say actually whether or not there's something that should or shouldn't be done differently.
So we really do have so much to consider as patients with CKD. And to reiterate what Dr. Kristin has said, please do, if you have any concerns, speak to your primary healthcare team in regards to your individual kidney health needs. So today, Dr. Kristin, we have discussed many more areas that we need to be aware of as patients in regards to our kidney health. We have discussed knowing your risk factors. We focused specifically on the risk factors associated with diabetes. We looked at referral to secondary care. We looked at the tighter targets for people with CKD. What is your final word of encouragement for the listeners?
I feel like the theme today has been urine. Make sure you get your urine checked. And if you're not sure about something, make sure you ask that question. But yeah, I think we focus a lot on ways. So help us spread the word about why that test is so important, as we said earlier, because I think not everybody's aware, even healthcare professionals, of why that test is really important. So help us spread the word and get more urine tests done.
Thank you so much for joining me again. Thank you so much for the information that you've shared. This podcast really is about empowerment and sharing information that's going to help people. And I know that this will help so many people out there. Thank you so much.
It's all right. It's a privilege as always.
Thank you for listening to Diary of a Kidney Warrior podcast. I truly appreciate your support. New episodes of this podcast are released every other Monday, so make sure you subscribe so you don't miss future episodes. And if you found this episode helpful, why not share it with someone who might benefit too? To stay up to date with the latest episodes, news and resources, sign up for the email mailing list and join the WhatsApp channel. All the details are in the episode description. Until next time, take care and choose to live.